Before I begin, I'd like to thank MUS, all core committee members, Dr. Prasanna and the organizing team here to give me this opportunity to be amongst you to, discuss ankle. So the next 30 minutes, we'll discuss the normal sonoanatomy of the ankle joint. I'll show you a gross, we'll have a small discussion about a gross anatomical picture, how you keep the probe, how you get obtain the image, and what does the image look like. All right. So how do we begin the ankle ultrasound examination? The patient is either seated or supine on the examination bed with the knee flexed at 45 degrees, and the foot lies flat on the table. It's flush with the examination table. And so the plantar surface of the foot is absolutely flat. You can either use a hockey stick probe of 8 to 18 megahertz or a linear transducer with a small footprint of 6 to 15 megahertz. Personally, I have been doing ankle ultrasounds with a linear transducer and they've worked well, but with, today all of you, we can try with the hockey stick as well. Now I've just divided this presentation, that's the roadmap, into different compartments. Ankle is evaluated into, divided into 4 different compartments. You have the anterior compartment or the anterolateral compartment where you look at the anterior tibiotalar joint recess. You look at the various extensor tendons. You look at the mid-tarsal, dorsal mid-tarsal ligaments, the AITFL, antero-inferior tibiofibular ligament, talofibular, anterior talofibular, and the calcaneofibular ligament. The posterior talofibular ligament is not well seen and cannot be evaluated on ultrasound. On the lateral compartment, you look at the peroneal tendons, the longus and the brevis. The medial compartment, you look at the medial joint tendons, the tibialis posterior, flexor digitorum longus, flexor hallucis longus. You look at the tarsal tunnel tibial nerve and the deltoid ligament. All these three, all the anterior, anterolateral and the medial compartments are also covered by the tendons are covered by respective retinaculum. The extensor retinaculum here, the peroneal retinaculum here, the flexor retinaculum here, which prevents the tendons from, prevents bowstringing of the tendons and keeps the tendons in place, closely opposed to the bone. Then you come to the posterior compartment where you evaluate the Achilles tendon. The flexor hallucis longus tendon can also be evaluated from the posterior approach, and we'll show you when we do the demo. You can have a look at the posterior tibiotalar joint recess for effusions, synovitis, and the plantar fascia. So that's how we will look at each compartments one by one and the structures. Coming to the anterior compartment, so this is the this is a gross image showing the the anterior tibiotalar joint recess. Okay, that's the tibia talus, and that's your probe position. All right, where the plantar surface, as we said, is lying flat, and you place your probe in the longitudinal axis along the anterior joint line. That's the image that you will get there on your extreme right. You see, that's the marker work. No. Okay, I'll use this. Because you have a. Okay, so that's the tibia. The one structure marked T is the tibia. Okay, that is the talar dome. The convexity that you see, the dip you see is the talar neck, and then you see the talar head on that side. The echogenic structure that you see marked with asterisks is the fat pad. All right, the anterior fat pad is an intra-articular but extra synovial, and so whenever you have joint effusions, this fat pad gets pushed anteriorly. All right, you see the below image where you can see joint effusion where the fat pad has been displaced anteriorly by the fluid in the anterior tibiotalar joint recess. You can evaluate for effusions, you can evaluate for synovial hypertrophy, and then you can also put in a power Doppler flow to see if there is any vascularity within. That hypoechoic lining that you see above the talar dome, all right, this is the articular cartilage covering the talar dome, and when you ask the patient to plantar flex the ankle, you will be able to see almost 70 to 80% of the articular cartilage when you move your probe from medial to lateral aspect. However, let us remember that ultrasound is not the modality to evaluate osteochondral injuries of the talar dome, though that's best reserved for MR. However, but you can evaluate a lot of the talar dome articular cartilage on the ultrasound as well. Yeah, so this is coming to the next part in the anterior compartment, the extensor tendons. Now we all remember our bony, we all remember the mnemonic, thund up is the mnemonic you can remember to for the extensor tendons from a medial to a lateral. As you progress from a medial to the lateral side, T is the tibialis anterior, okay, that's the largest and the most important tendon. H is the extensor hallucis, all right. Then you have the neurovascular bundle, the artery, the nerve, deep peroneal nerve, and then you have the digitorum tendons, all right. And you P is the peroneus tertius, not really well evaluated, and not a very important structure. So you see that's the gross image. The extensor tendons are covered by the extensor retinaculum, as I said, which will be seen as an echogenic thin band and sometimes may appear hypoechoic because of anisotropy. You have the superior and the inferior extensor retinaculum. Then your bony landmark to start is the medial malleolus, because we start with the medial malleolus and then we move our probe laterally. The first tendon that you encounter will be that of the tibialis anterior, all right, and then so on and so forth. The extensor digitorum hallucis tendon will initially be seen as a single structure, and as you move distally will get divided into multiple slips which go on and insert into the distal phalanx of the respective toes. Okay, the extensor hallucis will go on to insert into the distal phalanx of the great toe, whereas the extensor digitorum tendons will insert on the distal phalanx of the respective rest of the four toes. And the tibialis anterior you can trace superiorly from the musculotendinous junction up to inferiorly, where it goes and inserts into the medial cuneiform bone. So you can do the tracing in a longitudinal as well as a long axis as well as a short axis. So that's a probe position. As I said, you begin from the medial malleolus. You will now place these tendons, you will first see in the short axis, all right. When you move your probe laterally from the medial malleolus, that's the tendoicheles that you will see, the first tendon that you encounter. As you move laterally, you will see the extensor hallucis, you will see the neurovascular bundle, and then laterally you are going to see the extensor digitorum tendons, right. So that's a better anatomical. Okay, and that hypoechoic or echogenic structure that you see above the tendons will be the extensor retinaculum, which will keep the structures, tendons in place. So this is how the tibialis anterior will go. That's showing the tendons in its tibialis anterior goes and it inserts into the medial cuneiform. That's how the extensor hallucis goes up to the distal phalanx of the great toe, and that's the digitorum tendons, where they are in a common sheath superiorly, and as they move distally, they will split into multiple slips, right? You can then so that was the short axis image we had seen. You placed your probe transversely and generated a short axis image. All right. When you move your probe to 90 degrees, you will see a long axis image of the tendon, and you can trace up to its insertion on the cuneiform bone. Coming to the ligaments. Okay, let me come to the anterior and the anterolateral compartment. It's a okay. Let me show you the antero-inferior tibiofibular ligament. All right. So this is how the ligament. So antero-inferior tibialofibular ligament (AITFL) is a syndesmotic ligament. All right, and it can get injured in high ankle sprains. This is how the ligament So you have to know how the ligament runs. Only then you can place your probe in that direction and get an optimized image. So so this is the fibula, all right, the lateral malleolus, and this is how the fibers run, all right, obliquely, in an oblique manner from the. Actually now place a small towel, bolster, anything under the lateral aspect, so that you have a smooth gliding of your probe to see the structures on the medial aspect. Again, your bony landmark is the medial malleolus. When you start your examination of the medial compartment, you have to start from the medial malleolus. So in all ankle, in fact all MSK examinations, we have to be very sure of our bony landmarks, because that is where you start for your examination from. So this, when you focus this, that's the medial malleolus. Okay. When you keep your probe like this, you are getting an image, generating an image in the short axis. This is the medial malleolus. On top of it, you see the tibialis posterior. Just on its side, slightly more posteriorly, you see the flexor digitorum. All right, and then you see the neurovascular bundle. The flexor hallucis probably will not be seen in the same plane. You have to move your probe slightly more posteriorly. So you have the neurovascular bundle here, and you can also see the posterior tibial nerve just below the neurovascular structures, which divides into the medial and the lateral branches. The tibialis posterior goes and attaches to the navicular bone, with slips going to the cuneiform and the second to fourth metatarsals. The FDL goes and attaches to the second to fifth toes, okay, the distal phalange. This is again an image of the medial compartment only. These are the neurovascular structures you see in this. So as I said, it's a closed compartment, fibroosseous tunnel, the tarsal tunnel. This is the posterior tibial nerve. Any pathology in this area, because it's closed, it will, if there's a ganglion cyst or a neurogenic tumor, it will cause compression on the posterior tibial nerve. So you have to evaluate this area carefully for any pathology lying there. All right. So this was we had moved our probe. So this is the flexor digitorum. Just posterior to that, you see this neurovascular structures posterior to the flexor digitorum. As you move your probe slightly more posteriorly, you will then see the medial and the lateral talar tubercles. All right, and in between the groove between the medial and the lateral talar tubercles, you will see the flexor hallucis longus tendon. You will need to move your probe posteriorly. You will not see in the same plane as you were seeing the tibialis posterior and the flexor digitorum. So that was about the ankle tendons, the tarsal tunnel. Coming to the ligament in the medial aspect, the deltoid ligament, So deltoid ligament is a little tricky once you initially begin your examination. It has got multiple components. All right, it's got a superficial component, it's got a deep component, and these run from tibia to various other bones. I'll show you how the anatomy looks like. So the deltoid, the most important component of the deltoid ligament is the tibiotalar component. All right. The tibiotalar component has got an anterior tibiotalar component, you have a posterior tibiotalar component. The posterior tibiotalar is the one which is the strongest, most well seen on ultrasound, and you can actually distinguish between the superficial and the deep fibers of the tibiotalar component. All right. So the ligament has got multiple parts. As I said, it spans the ligaments which span from the tibia up to the talus is the tibiotalar. That's the posterior component. Slightly in the middle, as you move anteriorly, there are fibers which go from the tibia to the calcaneum. All right. So this is this was the tibiotalar, the posterior part of the deltoid. As you move anteriorly, all right, you will have the tibiocalcaneal component. As you move in the midline, there are fibers which run from the tibia up to the spring ligament. All right, and that's the tibiospring component. It's those fibers that are running from the malleolus up to the
not up to a bone but up to a ligament. That's a tibiospring. We can see all these on ultrasound. And as you move your probe more anteriorly, you will have the tibio-navicular component. All right, it's a little tricky and a little confusing in the beginning, but as you start doing and seeing it repeatedly, you will be able to appreciate those structures. Sometimes it's difficult to differentiate one fibers from the other fibers of the deltoid because they are in a continuum spectrum, and so that's how you see this image, that is posterior. All right, fibers, that's a tibiotalar component. You have the tibiocalcaneal component and the tibiospring component, and this is the tibionavicular component. To see the posterior parts of the deltoid ligament, which is the tibiotalar and the tibiocalcaneal, we ask the patient to dorsiflex. Again, this, what it does, dorsiflexion will make these posterior parts taut, and this is how you will see the image. So this is the probe. The probe one end is constant on the medial malleolus, and you are only rotating the distal part of the probe like a fulcrum. So that's the tibiotalar component running from the tibia to the talus. You see these, that's the superficial fibers. They are deep. They are the deeper fibers of the tibiotalar ligament, and on top of it, you can see the tendon of the tibialis posterior. Is that clear? As you move your probe anteriorly, see, this was the probe position. You've just now turned the distal part of the probe slightly anteriorly. You will be able to focus the calcaneum in view, and the fibers which run from tibia to the calcaneum are the tibiocalcaneal component. And as you move slightly more anteriorly, you will see the tibionavicular and the tibiospring and the tibionavicular components. We will see that in a demo. The spring ligament. The spring ligament has got three components. There are only one component that we can evaluate on ultrasound, which is the superficial component, the calcaneo-navicular component. This runs actually from the sustentaculum tali to the navicular bone. All right, from the passing above the surface of the talus. So you will see the spring ligament on top of the talus when it is passing from the calcaneum up to the navicular bone. That's how the ultrasound image will look like. You see, that's the spring ligament. You see that's the calcaneum talus. It's passing above the talus to go and attach distally on the navicular bone, and on top of it will lie the tibialis posterior tendon. All right. This is how position it. It's nearly horizontal, or maybe the distal end is slightly up. So that is how you keep your probe to see the spring ligament. Is that clear? I mean, is the anatomy of the deltoid and the structure. So that was about the medial compartment. Coming to the last posterior compartment, there are a fair amount of referrals actually you get to evaluation of the posterior compartment, both Achilles as well as the plantar fascia. So coming to the Achilles tendon, it's a tendon which is formed by the medial and the lateral head of gastrocnemius and the soleus muscles. They combine and join together to form a long tendon which goes and inserts on the posterior superior surface of the calcaneum. All right. All the tendons of the ankle we were evaluating in the short axis first, but Achilles is one tendon we evaluate in the long axis first. All right, so we probe. This is the position of the patient. The patient can lie prone, with the foot hanging on the edge of the table, so that you can easily examine the posterior aspect of the ankle and the heel. You keep your probe in the long axis. All right. You get this image where the Achilles tendon is a long tendon, goes and attaches to the posterior superior surface of the calcaneum. There are two important bursae in relation to the Achilles which you also have to see and evaluate. There is a bursa between the calcaneum and the Achilles, which is the retrocalcaneal bursa. You see this bursa, and you can normally up to some amount of fluid is normal in this bursa up to 2 mm, but if it is distended more than 2 mm, then this is bursitis, which can have various causes. Superficial to the tendo Achilles, you have the retro Achilles bursa, which normally it's an adventitial bursa. It does not have any fluid within it, and any fluid accumulation that you see in this area is always abnormal. Okay. Anterior to the Achilles, you have the Kager's fat pad, which you'll see seen as an echogenic structure anterior to the tendo Achilles. This is the tendon in the short axis. Alright, you moved your probe 90 degrees. So you evaluate the tendon for its for its bulk, for its ecotexture in cases of tendinosis. Or the Achilles tendon does not have a, like all the tendons, it does not have a tendon sheath. It has a paratenon, so you don't have a tenosynovitis, you have a paratendonitis when there is surrounding inflammation of its surrounding sheath. That's the point where it goes and attaches to the calcaneum. You can now also evaluate the posterior joint recess and the flexor hallucis tendon from the posterior aspect as well. We had seen the evaluation of FHL tendon from the medial aspect. You can also see it from the posterior aspect. Now what you do is you move your probe, once you've examined the Achilles, you move your probe slightly medially, alright, and as you move your probe slightly medially, the posterior tibio-talar joint will come into view. This is the posterior tibio-talar joint, this is the posterior malleolus, that's the talus, this is the fat pad, and you can look for any for joint effusions or synovial hypertrophy in the posterior recess of the tibio-talar joint. On top of it, you can have a look at the FHL tendon, that's a flexor hallucis tendon in the long axis, okay, from a posterior approach. The plantar fascia, the plantar fascia is a thick fibrous structure which attaches to the calcaneum, the posterior inferior surface of the calcaneum, and it as it moves forward in the plantar aspect of the foot, it becomes more superficial to go and insert into various structures. It has got three cords, the central, medial and lateral cord. The central cord is the most important structure of the plantar fascia, and you have to evaluate the thickness of the plantar fascia at its attachment site on the calcaneum. So that's the calcaneum, that's the probe position, you keep your probe like this in the long axis, you can see it's that plantar fascia attaching to the calcaneum, and you can measure its thickness here, which should always be less than 4 mm. You will get, there's a fairly common condition where patient has heel pain, plantar fasciitis, where you can see thickening of the plantar fascia, some irregularity in the calcaneum. So that's a commonly referred indication for ultrasound of the ankle. This is about it. Just a few important points to end this. Knowledge of sonoanatomy is the key when you're doing any MSK ultrasound. Obviously, holds true for ankle as well. Always your bony landmarks are the starting point for every thing. When you're looking at the anterior, you start with the middle malleolus, or you look when you're looking at the tibialis posterior, you're starting with the medial malleolus. Always be clinically oriented. Ask the patient his symptoms. Most of the times the pathology is going to be there where the patient points out or has a a clinical or has examination finding in that on a particular compartment. Always exclude anisotropy as a cause of the tendon looking abnormal by toggling your transducer. Again, common for all MSK examinations. And when in doubt, always compare with the opposite side. You need to do it often in MSK ultrasound when you are unsure of your findings. Just see what the opposite side is looking like, and then you can take your time to take a call whether it's abnormal or not. Thanks.